Yeah, the transplant data were very interesting. So three studies were presented back to back to back. The first study that was presented was an update of a very important trial called the FORTE trial, presented by Dr. Francesca Gay on behalf of the Italians. And the FORTE trial is a study comparing KRD induction versus KCD induction. And then for the patients who got KCD, they all went on to get high-dose chemotherapy, followed by consolidation with more KCD. And the patients who got KRD were randomized either to get only KRD or KRD followed by high-dose chemotherapy. And so essentially it was KRD for 8 cycles with a transplant, or KRD for 12 cycles, or KCD for 8 cycles with a transplant. And the updated data that they had presented at ASH a few years ago, and what's clear right now is that the patients who get KRD transplant are doing better than the patients who get KRD alone. And it's impressive in terms of if you want to look at PFS or you want to look at MRD testing, overall response rates, whatever. So the transplant is still super important, even for the very active regimen such as KRD being utilized. The FORTE trial also includes a second randomization between maintenance with lenalidomide only or carfilzomib and lenalidomide, and they presented data on that as well to suggest that the combination of carfilzomib and lenalidomide provides a little bit stronger maintenance therapy with deepening of responses. And they saw all these benefits across the board with respect to PFS and response rates across various risk groups of myeloma as well. So that's a trial that's ongoing, but so far corroborates the importance of incorporating high-dose chemotherapy into our overall upfront treatment for eligible patients. The other trial that was presented, the second one, was the IFM 2009 update. This is published 3 or so years ago in the New England Journal, but follow-up is longer now. And essentially, what we see in the follow-up is that and that was a study, to remind you, of RVD with upfront transplant or planned transplant at first progression. So not really a transplant versus no transplant trial, but a study comparing upfront transplant to delayed to first relapse transplant. And the French were pretty good at, in the non-initial transplant arm, of getting those patients transplanted at the time of relapse. And they presented data, again, that show that we have higher response rates, better PFS for those patients who underwent upfront transplant. And in their initial publication, there was some question about, well, if you got to MRD negativity with RVD alone upfront, delaying transplant, or if you got there with RVD and an upfront transplant, did those patients do the same? And the answer is no, they don't do the same in terms of PFS. And so PFS still strongly favors patients, as does who achieve MRD negativity with an upfront transplant. So far, overall survival in the two groups is the same, not unexpectedly, since most of the patients who relapsed went on to get a salvage transplant. So that's an important study as well. The third trial was EMN02, presented by Dr. Tavo, and that's an enormous trial that just keeps on giving data after data after data. And they're able to show with an older induction regimen, which is essentially bortezomib, cyclophosphamide, dexamethasone, in their trial, that the patients who underwent transplant are showing a separation of curves and overall survival after many years of follow-up, which is frequently seen in transplant versus no transplant studies. And their conclusion as well is that transplant has a very important role in the treatment of our eligible myeloma patients. So I think that at least in 2020, transplant is still an important part of our treatment. And the one point that still is frustrating to some of us myeloma docs who are transplanters is that roughly a third of patients who are eligible for transplant are still referred. So we have some work to do to try to educate the public and our referring physicians about the importance of transplant.